So with no further ado, then I'm going to pass you over to Dr. Sanjay Chima, and he's going to introduce our speaker for today. Thank you very much.
Thank you, Claire. So this is going to be the 6th webinar in this series, and this is going to be focused mainly on symptom management for patients with SIH and spinal CSF leaks. And this is one of the topics that, when we asked the patient body, was something that they felt was left out by lots of the sort of academic discussion and talks that have been done on this topic, but something that they'd find would be very valuable, both while waiting for diagnostics and treatment for SIH while undergoing these things and after treatment as well. Patients obviously have to manage with their symptoms. And although we've had lots of development in diagnosis and management of CSF leaks in the last few years, as you will have heard in the other webinars, this is still a topic where there's not lots of evidence, but there are things which do seem to help in clinical practice, and I'll be really interested to know what Dr. Wolf is going to cover in her talk. So just to introduce, Dr. Katharina Wolf is a neurologist as well as a clinician scientist at the University of Freiburg in Germany. She has a clinical practice specific in patients with CSF disorders, intracranial hypotension, as well as other high and low CSF volume problems. She's also involved in research and one of probably few people in the world who's got research funding specifically to look at CSF dynamic problems. So she works very closely with the big CSF Centre in Bern, Switzerland, and in Freiburg. And I think is going to be a brilliant person as a neurologist as well as a scientist to talk about this topic. So I'll hand over to Dr. Wolf shortly, and there'll be a 20 to 30-minute talk, and then we will ask the questions which can come in through the Q&A, as well as the questions which were submitted in advance.
Is working. So I'm really happy that you invited me to speak today, and thank you for this very kind introduction. You asked me to talk about symptom management, and since I'm here in Germany and probably there are also some international listeners, I like to just swiftly introduce a little bit and tell you a little bit who you're talking to actually here. And so this is Freiburg. We are at the border to Switzerland, south of Germany. And you already heard we work closely with Bern, where Professor Becks actually started his work with SIH. Before that, in Freiburg, we didn't know anything about SIH. And in 2018, he became chair in the Department of Neurosurgery in Freiburg. And since then, suddenly SIH appeared. And suddenly we found this disease, which wasn't there before. And that's probably what happens just now all over the world. And this is just some images. We are a very small city in the south, in the middle of the Black Forest. And that's today. Just when I arrived at the Neuro Center, you can see this here, this building. And at the side of the building, there is this graffito, and which I think it's quite a nice symbol of what we do here. We look into black boxes and just try to figure something out and make sense out of it. Our center focuses on pretty much anything that's is caused by CSF disruption. We look into diseases that are caused by CSF circulation that's somehow impaired, and we want to try and understand what does it actually do to brain health, because we really believe that there's more to it than just buoyancy or something like that. Of course, CSF is important in many mechanical ways, but having intact CSF circulation, we truly believe, is very important for brain health. This is how our CSF center is built up, and I'm really happy that we now got a position of a SIH nurse. We have different disciplines, which is so important and probably the highest challenge for anything who tries to start a CSF center, that we need to have neuroradiologists and the neurosurgeon interventionalists in one place, and of course also the clinicians who take care about headaches and all the symptoms attached to SIH. This is our team. You probably have heard about Professor Becks, who is one of the main drivers in Europe regarding SIH. I need really to admit, as neurologists, we don't think enough about CSF circulation. That's probably what you experience once you talk to a neurologist. We know a little bit about it, but if you need to talk, like the neurosurgeons, they are by training more into CSF circulation. And this is the true part where we need to get into a closer interdisciplinary team and learn from each other and learn from patients, learn from different knowledges and get this all together. And also, you need to learn you're just a little piece of the puzzle. This is me, this is Florian Volz and Ami El-Rahal, who do a lot of SIH surgery, CSF lead surgery. Mukesh Shah, who is also a consultant, he takes care of pediatrics, INPH, and other diseases related to CSF circulation. Our trainees, Manu Oversteins and Laura Crispa, who are really good by now. Laura is actually someone who does myograms and surgery, so she's at the verge of like really interconnecting the different departments, and of course the Department of Neuroradiology with Niklas Lützen, who does the most amazing images and finds the leak, which is so crucial in this disease, and also Charlotte Sander and Professor Urbach and Theo Demorat, and many more I cannot just tell you. And I'm going on about this because it's an honor to be part of this team, but it's also so important that you team up, that teams build and drive and enhance this field. So by now we look into 500 consultations per year. I run the outpatient clinic, and there is a lot of like trying to figure out who, like the preclinical challenge. I will talk a little bit about this later on, and also the post-treatment care. And 500 is just a number of incoming requests, not the patients who run through our hands later on. There are more than 400 surgeries that have been performed in the center, and of course, there's as a center we offer patches and any kind embolizations, and we try to enhance the field by research. This is what I learned I should talk about today, and I said yes. First, I was asked whether I could talk about symptom management. I just said yes, of course I can do this, and then I looked at this list and said, oh my goodness. This is a lot, and a lot of things we actually don't know. And I took the liberty to rearrange this a little bit into a way I thought makes sense to me to talk about. So I would like to start and talk about what to do while waiting for the diagnosis. And I would always say for definite treatment, leak closure in SIH, then the next step would be, okay, the decision, what happens if the leak isn't closed? What is actually the prognosis in SIH here? And what is the prognosis after the leak is treated? And I would always talk about definite treatment, closure of the leak. And as the last bit, I would like to talk about the post-treatment management. What are we looking into here? This is just a map of the countries where actually CSF centers are located. And you see there's a lot of black. And even although it seems like we got some good coverage in Northern Europe and in Canada and US, we all know that it needs to be enhanced. This is the numbers of if we look into PubMed, that's the database where we do find our where we look into research that's out there. And if we just do this, and I've recently looked into it, and we see about 4,500 results of scientific work that's out there on SIH. That's quite a number. If we look into the quality of that, it's mainly case reports. It's case controls, it's retrospective data. It's not the good medical quality data we actually want to have to base our decisions on. So this needs to improve. And if we just compare it to another disease like subarachnoid hemorrhage, got the same incidence as SIH, and it doesn't even fit on the screen if I look into research. So this is what we compare to, and that's what we need to have in mind. If you listen to me or anyone else talking about CSF leaks, we actually don't understand yet what to do. Of course, it's not just science, it's maybe a little bit experience. And from that, so making a good educated guess, these are our numbers. And I've been working in the center since 2023, so I've seen more than 300 patients myself, and of course I benefit from the team. And by now we have increasing numbers of more than 120 rising just SIH per year. And also there's something we can base our knowledge in. We already work on SOP, so standard procedures, and we have a CSF board, and we have standardized aftercare. Nevertheless, you always have to keep in mind the patients we see, they are usually already advanced in the diagnostic and in the therapy. So they have already had imaging. They have already had their lumbar blood patch in many, many cases before they come to our tertiary center. So you always have to keep that in mind as well. Let's go into the actual what to do. The clinical challenge in SIH, we know it all. It's mainly orthostatic headache in the beginning, and it's got an acute to subacute beginning in most of the cases. But also we know there's a high inter-individual variability within the patients if we compare them, and over time symptoms change. So there is not one fits all, and I can probably repeat this before and after treatment. There is not one thing that is I can recommend to any patient. We really need to listen what is the main complaint of the patient. Let's look into data. Rest, drink, wait. The first care in CSF leaks: lay in your bed, stay there, drink enough, and wait what's happening. And sadly enough, that happens to many patients. Like, that's all that happens to many patients. And there is actually not a lot of data, and there's just some data saying, okay, it's effective, whatever that means, in a quarter of patients over 2 months. Probably, I would still say, okay, if it starts like that and you have immediate symptoms, please rest a little bit and listen to your body. Try to get up if you can, because it's very important to stay conditioned, to work your muscles while laying in bed. But take care, respect your symptoms. We will talk about risks in SIH later on. And there is a risk of sinus venous thrombosis and brain bleeding and so on. And beforehand, before you don't have acute brain imaging, you never know. So stay at bed, but try and get out as much as you can. Respect your symptoms, but try to move. The next recommendation, caffeine. It's everywhere, like all the guidelines, German guidelines, all the guidelines I know, everybody was saying, okay, what do you do? Rest, drink, wait, take some caffeine. There is a little data on this, and it's quite curious, and probably we need to discuss this. But what does caffeine do? If you take caffeine, it actually reduces your CSF production in the acute phase, and it increases pain perception. So we should probably discuss this a little bit. I think why it probably works, and we know it works for some, is that in the prolonged stage, CSF production, if you continue your intake of caffeine, the CSF production in the long run will increase. So probably what happens, if you're a coffee drinker and add caffeine to that, you benefit of it. But also we need to look into this pain perception area, since we know that there is some headache that persists after treatment, and so probably we have to look into that in a research way, but it's all we have. And if I would say, if you benefit, take it. If not, don't. We base our recommendations here on data that's the clinical recommendations. We base that on some RCTs. RCT is something that's the highest level of evidence. So we test something against placebo, and both parties are blinded, patient is blinded, rater is blinded, and then you see the outcome, and that has been done in postural puncture headaches. And we know postural puncture syndrome is quite similar to the syndrome in SIH, so probably we can get something out of this data if we talk about symptom treatment in SIH. But if we look into that, there is some data on caffeine. And the actual recommendation of caffeine intake is really, really high. And if you look in the numbers that have been investigated, it's just 20 patients. They're really low. I don't know about the quality of this data. And you see that some of the data even favors placebo, and just other data favors caffeine. So the data is really not that good in this regard. And the same with theophylline. There is one drug that's gabapentin. It's an anti-epileptic drug, and we use this a lot in headache medication as well. And this data, again, on very, very few patients, it's quite favorable. Although we have in mind that all those drugs that need to be taken for some time before they get their effect, and they need to be started low and then increased over time, with also some side effects we need to keep in mind. But if we we're right now, we don't have anything at our hands. So I think we should do whatever we can to improve the symptoms. There's also some data on steroids, hydrocortisone, and it's also not really that good. I know it works in some patients and others doesn't. We use it, some use it even in hypertension, so in increased pressure, and say it reduces CSF. So there is a lot going on. Let's face it, steroids are just a very strong painkiller, and I think that's the main effect that they can have. With a lot of side effects, it's never a permanent treatment, but once tried and maybe tapering it, it might be worthwhile trying. I think there's something we need to keep in mind, and I think it's actually very useful. The challenge is to get a doctor who does it to you. So we can block nerves, and it's really not that difficult to do that. And there is this greater occipital nerve that's in the back of the head, and they can be blocked by some local anesthesia, and usually it's combined with some steroids, local steroids. Of course, they get systemic, they go into your body as well. You need to, your doctor needs to take care about this and advise you on this. But it's worthwhile looking into those nerve blocks. They have been shown to be effective in some case reports. And in my experience, sometimes it does the trick. But it's same here. If you don't try it, you don't know. So I think it's always worthwhile to do it, especially since it's not a systemic or not a highly systemic treatment, and you don't need to take your medication the entire time. As we all know that it fluctuates, and you don't have all the time the same symptoms, and try being on a preventive symptom if you don't have headaches that much and so on. There's always a debate on this. Again, it depends on the individual symptoms, and I think those nerve blocks are really worthwhile looking into. Same with sphenopalatine ganglion. A ganglion is something where nerves have their connection a little bit, if we want to explain this. We can block this, and this is something that's also quite common in special, in some forms of headaches, especially face headaches, trigeminal headaches, and that ganglion can be reached through the nose or through some injection over the cheeks. So it's not that easy to get someone to do that. It's not hardly very, very difficult, but you probably need to find an anesthesiologist to do that. But also there are some good reports on sphenopalatine ganglion stimulation and blocks in CSF loss symptoms. Also, what to do while waiting. There is an increased risk of thrombosis if you're immobilized. If you cannot get up, you have an increased risk of thrombosis and then thromboembolation with all the risk of that. And also we have a risk of sinus venous thrombosis through the CSF loss itself. The sinus venous are in the veins draining the blood from the head. And there is no evidence, no recommendation in this regard. Our guidelines say, okay, if you got symptoms, the second you get up, if they're severe, you should get some thrombosis prophylaxis, based on the fact that you probably remain rested most of the day. If that's the case, you start your thrombosis prophylaxis with start of the symptoms. In the long run, we know that the body adapts. You probably don't need to do this the entire time and can stop it. After, usually in, like if I compare to spinal cord injury, it stopped after 8 weeks, but it probably needs to be looked into with the individual. Then our guidelines are vague. If you have your symptoms within over 30 minutes, so you're up and then you start having symptoms, you probably don't need prophylaxis. You are mobile enough to prevent thrombosis, but we don't know what's in between. And I would just say, okay, it probably depends on how severe the symptoms are, how immobile you are, and then I would like debate on whether to put a patient on prophylaxis. Okay, this is the first part. And now I would like to talk about the prognosis in SIH, and I have a clear answer on that. Again, SIH is a disease where we lose CSF at some level of the spine. You see in this image, I go back once more. This is now a normal brain and cerebellum and brainstem looks like, and then you lose CSF and the volumes try to compensate. The blood increases. We got some degree of brain sagging that's shown here. So this is up and then it goes down. The veins within the brain, they get larger. We might get some water egress between the dura and the brain, so subdural hematoma or hygroma, and the meninges, they are hyperemic. That's why they enhance, so they get a little bit larger as well. And we know those are the common signs we look into if we try to diagnose SIH or try to figure out how likely is SIH as the diagnosis if you do MRI. And we know most of the leaks are currently caused by ventral leaks, and then we have lateral leaks. Ventral and lateral leaks are dual tears, and then we have this type 3 leak, which is a CSF venous fistula where the CSF egresses directly into a pathological vein. Let's talk about the prognosis if you do not treat the leak. I've already told you that one of the signs we also evaluate in the burn score is subdural hematoma or hygroma. You can see this in this image, is an MRI. And this is already quite large, not super large, but it's something. If you just see it, okay, you start thinking, does this patient needs evacuation of that? Probably it's okay to wait for it, but you need to check on that. Data, again, is not perfect, but if we've got some data, retrospective data, case data, and the current estimate is that 25, so 1/4 to 40% of the SIH patients develop some form of hygroma. It doesn't need to be this extensive, but we need to have that in mind. It seems to be more common in the older patient cohorts. then we talk about 50 years, so not really that old. And mainly we see this in bilaterally, but 10 to 50%, 15% are unilateral as well. I already mentioned sinus vein thrombosis. This is an image of one of our patients where you can see extensive thrombosis in this sagittal sinus, and it probably affects 1 to 1.5% of the SIH patients. And if we have that, we have a high risk of complications, of brain bleedings, and so on. The thing with those patients is that you have to walk the line. The treatment of the subdural hematoma and the sinus venous thrombosis is closure of the leak. So you need to find the leak and to close it while you have to anticoagulate the patient. And with that, you have an increased risk of bleeding again, while you have to go into invasive diagnostics and so on. But luckily, so far, the patients at our hands have not had any severe complications and could be healed. I think you need to consider sinus venous thrombosis or hematomas if you get a sudden change in symptoms. So if your orthostatic symptoms all of a sudden get really bad, holocephalic, you get more pressure, and it's, in my experience, you cannot, usually you would expect that it's changes from orthostatic to worsening while laying down, but usually patients cannot tell at that stage. But if you get sudden severe headache that's even more severe than the onset of SIH, you need to think about this. We need to talk about superficial siderosis. That's where blood deposits get surround, or they deposit, the drain doesn't work anymore. And where the blood comes from, we don't know that yet, but blood deposits are stick to the brain tissue and the spinal cord tissue. And usually at the beginning, you don't have any symptoms, and then it gets more and more, and then you get dementia, deafness, ataxia, walking disabilities, hearing disorders. And once it is there, currently, we don't think we can remove it. So this is usually we find this in long-standing SIH. The median onset is after 10 years, and it's usually in SLAC-positive patients, so patients with dual tears, type 1, type 2 leaks, but it has been found also within patients with CSF venous fistulas. So this is a serious risk, and this is one why, even if you are well, a leak needs to be closed. If you look at our own data regarding superficial siderosis, we found something which made us a little optimistic, but it's just also, it's a few patients in this data set, but some of them even got better with their symptoms of superficial siderosis after leak closure. So we need to close the leak to prevent progression, but we might even improve the symptoms with patients with superficial siderosis who already have the sequelae of SIH. Then we have a rare complication of SIH, that's bibrachial amyotrophy. In my experience, those patients, they don't have as much orthostatic headache, but they lose their strength in their muscles, usually at the upper limbs. And currently, the cases described are SLAC positive, again, ventral or lateral dural tears. Another potential complication is spinal cord herniation. Usually, we think it's only in ventral leaks where the spinal cord gets attached to the leak. And with those, you can get like scarring, and the spinal cord sticks to this leak. And in the long run, you get walking disorder and spinal cord symptoms. Very important, we need to talk about dementia. And if we look into literature, we usually look into this frontotemporal-like brain sagging syndrome. That's another entity. If we closely look at that, we get brain sagging dementia, and some of those do have leaks. It's one of the severe complications of SIH. And if we have frontotemporal dementia, we need to think leak and look for that. Not all of those patients will have actual leaks. But as one of my observations, when I started working here, I was saying, okay, let's look at how those patients actually function on a cognitive level. And we, SIH patients are usually between their 30s, 40s. They are put out there from their normal lives, but also those patients, they tend to cope very, very well. You can talk to each other, we can discuss and so on, and you think, okay, they're pretty much normal. And if you start testing them, I found that 30% of those normal SIH patients did have mild cognitive impairment, and 50% couldn't, showed some impairment in visual executive function. And that got us thinking that it's probably not just a brain sagging, it's more CSF circulation, the impaired CSF circulation. And this is just the observation, and it was so impressive that we published it, and still working on this and trying to understand this, but it's probably part of what's usually called brain fog, this entire syndrome. I don't think that brain fog is a good terminology, but we do see patients who actually perform worse than other demented patients. So let's sum up. If you don't treat the leak, if you don't go for definite treatment, you are at risk of brain bleeding, sinus-venous thrombosis, superficial siderosis, rarely brain sagging dementia, rarely spinal cord herniation, as far as we know, and biparietal amyotrophy. Again, this is very, this data that's not prospective, retrospective, and still in a way of guessing, but that's what we already know. So a leak needs to be closed, and if you get treatment for a leak, you need to have follow-up to make sure that the leak is closed, no matter how you feel. If you're good or bad, you need to have follow-up. That's very important. Now, what happens if your leak seems to be treated? And to me, lumbar epidural blood patch, it's important to do that, to enhance the buoyancy, to enhance pressure, and it's the first line treatment, and many patients benefit of it, which we know from a lot of data. So you get short time relief in more than 80%, so you can finally get out of bed and prevent further deconditioning and other secondary complications. But we know that epidural blood patching does not heal SIH, and most of the patients, despite being better, are not healed. The leak is not closed. And in this regard, we really need to talk more to neurologists, that we don't expect just an improvement, getting better 30-40% or something. We really need to get healthy patients. We know already that if we look into in the long run, then more than 70% have a persisting leak after being treated with a lumbar blood patch. So again, follow up. No matter what we do, even if we do targeted treatment, if we do surgery, blood patching, anything, we need to follow up that the leak is actually closed. If we compare outcome being treated, definitely treatment, so leak closure by any kind of treatment we know by now, so transvenous embolization of CSF venous fistula, surgery for all types, we know that more or less 90% have a substantial improvement. So they get very much better, and more than 60% get complete resolution. That's the summarized data of what we have from large centers. Our own data, of course, I'm biased in that, shows very nicely that headache severity improves very nicely. We see this, the HIT score is something that measures the impact that headache puts on a patient. And we have, before treatment, we have a high average with all our patients. And after that, the average decreases tremendously. That's much larger than any headache treatment, typical headache treatment studies you look into. If you look into headache treatment with just with painkillers and so on, that's an effect that's absolutely outstanding, and quality of life gets much better in definitely treated patients, so after surgical repair, that we ensured that follow-up is definite. Also, I think something we really need to talk about is working capacity. And I know this is one of our first data now on this, and it's not much, not many, covers many patients, that's what I wanted to say. But beforehand, no one could go to work and lost a lot of money. Social security system lost a lot of money. And after treatment, they got back. So we need timely treatment. That's just, there's so much money lost in that. Health and money as well to the individual and everyone. And that's probably numbers we need to talk to our politicians. Nevertheless, and you asked me to talk about post-treatment symptom management. If we look in our own data, and follow-ups tend to decrease in patients participating, we still see after 12 months that a quarter of our patients still got severe headaches. You see in this pie chart, the red is severe headache, green is no or almost no, not impairing headache, and yellow is some headache impact. And it decreases, it's very nice, it's a huge effect, but there is still something going on after the treatment, and despite we've definitely closed the leak. So we need to talk about this. In the next part, I would like to talk about rebound hypertension, what we do, what our experience is on that, and persisting orthostatic symptoms, and headache treatment in general, and what we can possibly do about other symptoms. Before I go into that, I would like to mention something that's also very important. It's a journey, and before the diagnosis is made, many patients encounter doctors who don't believe them. They have a disease, nobody can tell what they're having. It's like headaches in general have that, and also like you cannot measure pain, and it might be better to have a broken leg or something you can show that's actually broken and doesn't work. Here you have all those weird symptoms going on and everything happening all of a sudden to someone who has been healthy before that. So that does something to a person. And after the treatment, sometimes we still face the same problems. I think I know this in neurology for many rare diseases, that once you get a diagnosis that's rare and not everybody is familiar with, the medical system tends to push you back. They just say, go to a specialist, go always back to a specialist. And then they don't do what they can. And that's something very important. I always try to get in my consultations, I try to enhance and get the general practitioners and the general neurologists to do and try to take care of the patients. They cannot just come to Freiburg or to Queen Square or King's College or whatever. You cannot do this. We cannot do all the treatment. And they are afraid of that there is some risk and they might do something wrong. And then in this matter, they just don't do anything. And that's something we really need to improve. And also, again, it's a journey. It's a journey. You all of a sudden are at a point you can heal. You might have secondary complications from immobilization and so on. And also, I think we need to talk that we are all human. It does something to a soul and to a person if you're sick all of a sudden, if your social life and everything changes and you might be the most resilient person, you need to cope with that too. And in my when I talk to patients, I sometimes it's hard to overcome that, because also there is something like many patients have learned not to trust their neurologists, and I think they're probably right in many ways. But now after the leak is closed and symptoms are still there, we need to figure out, we don't understand the entire system, and we need to listen to the symptoms and try to figure out how to improve them in each individual. And sometimes we need to go back to, again, headache treatment, maybe something you've heard before and hasn't been right for you. And now we need maybe to figure out a way to improve symptoms in order to get a person back into life. And now we are in the same situation again, that the doctor tells you, maybe we need to treat your headache. And that's something that needs personal trust, and also the willingness and the resilience. And it's a huge challenge in this entire structure, in my experience. So first part, I think many patients now I meet are very afraid of rebound hypertension and SIH. Of course, that happens. What is rebound hypertension? So very basically, in very easy words, we close the leak and then the CSF amount increases and you get the reversed symptoms more in the front and maybe behind the eyes. And in our experience, it's usually short period of time and then it resolves. So very, very few patients stick to rebound hypertension. We treat this with acetazolamide, usually low dose, few days as needed, and then we taper off and that's absolutely fine. There are side effects, we need to take care about them. And the usually if the patient is informed what happens, that it doesn't, your nerves don't are not destroyed if it tingles, then it usually most of the patients are fine with that. If the symptoms prolong, are very severe, I tell the patient, okay, then you need to see an eye doctor. Also, if you have visual impairment, of course you need to see an eye doctor. And if it really sticks to a patient, we need to look into differentials. Sometimes there might be iron deficiency or hypervitamin A treatment, skincare. Sometimes I have one patient, I'm really sure it has an underlying IIH, and she needs treatment for that, and she's now much better. Also, we need to look into blood pressure, so especially the second number in the blood pressure, if that's increased, then you get high pressure symptoms. We need to check for that. And in case it's 6, of course, we need to do some lab work, maybe see another imaging. We need to think about this, either whether the leak is up or if we have sinus venous thrombosis. And if it's a clear rebound hypertension, never do lumbar. I don't do any measurements in that in regard of ITP measurements. So what else? What to do? Avoid obstipation. So anything that puts pressure on the belly will increase CSF pressure. Increase upright time. Now you need to do the opposite. So the CSF and venous pressure can get lower. And I'm really, really convinced that cardiovascular training and training of CSF circulation and blood circulation helps. Recurrent orthostatic symptoms, of course, if it's just there again, you think there's a leak. We all know it happens often and there is no leak and we don't understand why that is. But of course, you need to be sure that the follow-up imaging was adequate. We need to think about which type of leak. Is there a chance of reoccurrence or another leaks? Maybe in rare cases of CSF venous fistulas that might happen. And then we need to have adequate follow-up. Also, what could do orthostatic symptoms? Caffeine withdrawal can do that. Again, blood pressure and POTS symptoms, we know it can go hand in hand. We need to talk about this. If you are deconditioned, have laid down for quite a while, then you go up and your venous pressure and blood pressure just sacks, and then you get orthostatic headaches with that. And what can we do? I learned that from patient. Binders, swimming, compression helps. Other than that, we are quite clueless what to do. Persisting headaches, and here we need to talk again. So what has been there prior to SIH? I find a lot of patients who had migraine before the occurrence of SIH, and the CSF circulation disorder triggers the migraine. And then they are stuck with a chronic migraine despite leak closures. And then we need to tackle that with all we can. And that helps. Same with IIH, same with SIH. And we need to talk about this. most of my patients tell me, okay, beforehand, I had just normal headaches. I had severe headaches, needed to lay down, and I had some nausea. And next day, everything was okay. That was their normal headache. So they did have migraine. And now they are just in severe chronic headache with peaks and so on. And it's migraine. We need to treat migraine. And every once in a while, I catch other primary headaches that can be treated in different ways. Also important, in my experience, not that common in SIH, is medication overuse and medication overuse headache. If you pop pills and medication painkillers, then you get more headaches. So we need to talk about this, and it's very common knowledge in headache specialists, and it usually feels bad for the patients because they get the impression, okay, now I did something wrong again, and what to do. But we can treat that and go usually with some preventive medication. We can reduce medication overuse and get over this medication overuse headache. What else? Exercise is a very, very good headache treatment, and self-care, like trying, most of patients do that, but it's also good to keep in mind or to know, okay, if I'm better with myself, like every pain is better if there's a good self-care, if I'm stable, if I'm relaxed as much as I can do, reduce stress, regular sleep, regular eating, regular drinking, and I always look into, is there something else we possibly might improve? So musculoskeletal problems, bruxism, which is like if you bite your teeth overnight, you usually have this tightness here. And if there's anxiety, depression, maybe because of the disease, because of all that happened, we need to talk about this as well. And this is important in chronic pain, and for some patients, it improves, and then over time we can handle the symptoms that are still there. I've already mentioned general pain therapy. We need to take care that there's no medication overuse, so no more than 15 days per month with regular pain killers like ibuprofen and so on, and avoid opioids. That's the end of the story. Never take any opioids. And we need to talk about what can you do in acute worsening. And also we need to listen what is actually the symptom there, and try and get an idea out of that. And again, we can talk about infiltration that helps many patients, and probably look into new target therapies. And if we talk about chronic headache therapies, just take anything we can, and we might just say it's chronic migraine, so we can do anything we can in order to just get something better. So let's sum up. I talked too much, I think, but I'm looking forward to the discussion. In CSF leaks, we need to find and close the leaks, point, period. It's just, there's nothing else there. Post-treatment symptoms and pre-treatment symptoms, we need to listen what is the actual major complaint and try to figure something out, how to improve that. And in headache therapy in general, we need to figure out the phenotype and then try and go for that, and usually we can reach an improvement. With that, I will skip saying I hope to see some of you. Claire, I know you're going to be in Amsterdam, and we trying to improve as well, and trying to build a network in Europe with the CSF centers we have, and try and teach and get more doctors to be trained in SIH diagnostics and care. And with that, I would like to thank you, and I'm looking forward to the discussion.
That's brilliant.
Thank you very much.
Thank you so much.
That was brilliant. I'm sorry for giving you such a wide remit of topics to cover, but I think you did that brilliantly and tied everything together. We've got a few questions that have come in from patients in advance. We don't have many questions from the Q&A today, so just a reminder, if people have got any questions about anything they're not sure about or anything they've been dying to ask, then to use the Q&A section on Teams. Shall I start, Claire, and then
yeah, you start. Work away.
Yeah. So, as you said, sort of right at the start, it's very important to work as part of a multidisciplinary team. Otherwise, it's very difficult to manage this condition. And I was very jealous that you've got a specific CSF leak nurse, and I think even a physiotherapist. One of the questions that came in from the patients was, do they recommend any specific exercises that patients can do while they're on bed rest or while they're symptomatic, sort of while they're flat, to try and avoid deconditioning or thromboembolism?
There is, just honest, there is of course no specific training in that. And we just try to figure out just improving venous pressure is just, we just recommended like trying to bicycle in bed. You can do all this type of thing, laying in bed and getting some just stretching bands and trying to keep muscles working. We all know, like anyone knows, if you have a patient admitted to a hospital that needs to stay in bed for 10 to 14 days, even the healthiest person deconditions with muscles, with circulation problems, and that's something that's probably just from knowing there we recommend it. But of course there is no specific training to say, okay, this is perfect, you can do this. And what do you do?
Yeah. There are exercises that people with things like postural tachycardia syndrome, and there's a POTS charity website, for example, that has some exercises about things that people can do whilst flat. And sometimes if patients have asked about that, I've directed them to those sort of exercises, but there's no evidence they help with the symptoms of CSF leaks, but they may help to keep people conditioned, and then maybe that will lead to a sort of better prognosis and less risk of other complications. But yeah, it's something that's not been studied at all, isn't it?
Yeah, later on, so after, like, if a patient gets up a little bit, and usually in my experience, there's a lot about positional headache. Like you change position, and then the headache gets really bad in between, and then it just wears off. And I know what I sometimes point out, that we got some physiotherapist advice from the SIH groups. They have similar symptoms in the long run. And there are some YouTube videos on that, trying to exercise while not bending that much. So probably doing dog position yoga is just something nobody would like, even after a successful leak closure. That's not a good idea to start with something like that. But in a lighter version, just try and change and but of course do muscle training and some bicycling while laying down.
And that ties nicely up with a question that was submitted, which is, should someone with a spinal leak avoid yoga and Pilates? And I suppose you've got the patients who are sort of semi-functional and they're trying to keep up the muscle mass, and then you've got patients after blood patching or surgery and they're starting to pick up kind of more normal things to do in their life. What's your advice normally? Just avoid?
No. Yeah. Seriously, I think let's go one step back. I think the data is so scarce. Respect of symptoms, but not living in fear. I think like having too much avoidance, living in avoidance, it's just not living a life. And probably it also a little bit depends on what we've done. We have our schemes after surgery, and the likelihoods of reoccurrence is so low, and now they need to go into exercise and living the life, going back. And that might be stressful and difficult in some cases, and they need to like push out, but I don't give any recommendations on what not to do. If a person is a yoga person and that gives you something, and I think yoga is a very nice exercise, breathing in and out, and you just, if you don't feel well while doing like those head down things, then you don't do it. First day, second day after surgery, I don't recommend heavily twisting and so on, of course. But I think there is some data out from the Cedars-Sinai, from Schilling, where they figured out that yoga might be a risk factor. But let's be honest, it might just be a LA cohort that's between 35 and 45 and mainly women. So what's the likelihood of women doing yoga in LA? So I think let's be realistic about that. And if your body doesn't like it, you just don't do it. But other than that, I think yoga, Pilates, and those kind of sports are very good especially in chronic, if you have chronic headaches, chronic pain. And they build nicely on the spine, spine muscles and so on. So that's something very important to rebuild on that. So I never forbid anything.
Brilliant.
And then slightly linked to that, so you talked about bed rest right at the start, and this is often a thing that patients are advised to do, and something that's come from us, I think, as medics, bed rest might help some way in healing the CSF leak. And often patients are understandably worried and terrified of anything that may then worsen their symptoms or worsen this CSF leak that they've been found to have. Is there anything that you'd advise patients about that if you get asked? Do you think normal sort of day-to-day movements of things are likely to make things worse or not?
I think in my experience, to make it short, I think it depends on the stage they're in and the severeness of symptoms. I think in the acute phase, I would advise them to rest, just because before, which I'm not the general physician or not the first neurologist they talk to, but we all know it's not very common, but you can get comatose and worst case brain herniation. So in the beginning, before I have some idea how that brain looks like, I would recommend to rest, try to get up. You need to go to the bathroom, take a shower, try and see how you feel. Do exercises in bed, but mainly rest, at least for the first couple of days, and until you get a feeling, okay, your body is wonderful and can compensate. Of course it does. We all know that everybody gets better in the long run in terms of severity of orthostatic headaches. And if that gets better, I would say, okay, then try and move. But as a first advice, I would stick to the resting, just because of the fear of some brain bleeding, like in the first part, especially in the young patients where you have like this dynamics you cannot just lay hands on. I would stick to the bed rest as well.
Thank you.
And so one of the things that's present in many countries where people experience CSF leaks is there's a delay between symptom onset and by the time they get to a CSF leak centre like yourselves. What do you think that does in terms of outcomes for the patients in the long run, that delay?
We know already that prolonged time till definite treatment has a worse outcome. From what we can tell by now, I think the data refers to about 350 patients, mainly we have this mixed cohort where we have the same outcome for the burn group. Did it, I think for the first time they said the time matters for the outcome with the mixed cohort, meaning different leaks. And we know it from CSF venous fistulas as well. So from symptom onset, so the time delay to definite treatment has an effect on outcome, meaning that the general outcome, mainly headache or pain burden, is higher in those patients. That's the data we have now, and I think that's already pointing out, and we find like everybody can reproduce that. Nevertheless, I don't understand it yet. I think if we need to discuss and see what else we can do, because we will not change the world immediately, and see and how to improve that, and getting more. I think doing more research hopefully helps us to discern better what to do beforehand, so the patient gets out better after definite leak treatment. But I think there's also this discussion about central sensitization and so on. But I see that many patients that, like, some of them, they get better even after long-standing disease. and then some don't. And there might be some differences in how the brain works and has a pain sensitivity. Like, as we know, some people don't have headaches ever and some do.
Yeah.
I don't know. Well, maybe, but I'm not happy with easy explanations yet.
Yeah.
But
and you know, and the fact is we don't know yet, and we do need more data. Yeah.
Yeah.
Yeah, agree. I think there's lots of things that we can do to try and sort of improve treatment for patients. So one of the patients has asked if there's anything that a patient can do to try and optimize their recovery or long-term prognosis.
Okay. I think I repeat myself. My belief and it's belief, I know. But from all I know of CSF circulation, I'm convinced that exercise, sleeping well is helping, and going back into the orthostasis, if you can. I'm really convinced that CSF circulation and compensatory mechanisms need that. Otherwise, they get disarranged. And if I just, that's something, something I get from the patients, and maybe you can share that, your experiences as well. But the patients who are really bad after treatment, they tell me, okay, I needed to push my way up somehow. And so if you can, I think it's important to try and exercise the body positions again, and doing some cardio sports. So getting like the changes in volume going, ups and downs. But that's a belief. That's just like from all what we know what brain health needs, all we know what it's good headache preventive sports, cardio sports. It's a preventive for dementia to do cardio sports. So that's something I try and get the patients, if they can, to do.
Brilliant. You touched on some cognitive impairment, a study that you published, which is exceptionally good to see something out there about that, because I think you're right, brain fog doesn't cover it. But we have a question here about what are behavioral problems associated with having a leak, and the specific question is, are there issues with kind of anger management and, you know, low tolerance to frustration, that kind of thing? Is that something you've seen?
Definitely. Definitely. And yet I don't have the answer to it, to why it is. But patients tell us, we see it, of course, in severe brain sagging dementia patients. We see this change in personality and fluctuation, and it seems plausible. And if you look into the neural networks that are involved in that, and yet we don't fully understand. That needs to be honest about it. And I know there are studies about psychological changes in migraine and other pain, chronic pain diseases, and you find this as well. And probably there's a huge spectrum depending on resilience.
Yeah.
And probably that, I believe, to the neural network disruption.
Yeah.
You probably can have both, and it's difficult to in a scientific way to split that up. But
yeah, it's just a symptom that's hard for the person to manage and hard for their family to manage as well.
Yeah, but it's important. I think it's important, and thank you for putting this question out, and for you as a CSF League Association to give space to talk about this.
Mm-hmm. Yeah.
It's so difficult in most of societies to talk about psychological problems, either whether they are clearly based on neural network or whether it's coping strategies. And it's important to talk about all those. We are humans. And
there's a burden with any chronic illness, but when you layer on cognitive impairment,
you're healthy, all of a sudden you're out. And with all your life, not just working, everything, and it's then you can get anger management problems. I would absolutely agree.
Yeah,
That's
completely. Yeah. Thank you.
Great. And then just moving on to the complications that you talked about, there's a few questions about long-term complications of spinal CSF leaks or SIH, which you've answered lots of those questions already in the talk. The question that maybe I haven't quite covered is in patients who have mild symptoms of SIH, who don't want to go for a treatment like surgery, which could have risks. How do you think those patients should be followed up or monitored for any complications in the future? Or what do you do in those patients where they've got very little symptoms, they're not that keen on having surgery?
Try and understand their reasoning. Of course, you always have to accept if a patient doesn't need it. And I can absolutely understand that it's difficult, especially if you're well, to go into surgery. That's a difficult decision on someone. But then I show them the data and explain to them what the likelihoods of happening. And currently it's 10% risk and probably higher having a long-standing leak. And once we do have the complications, we are not likely to resolve them. And we have, it depends on the hands. In our hands, it's a risk of 3 to 4% once. Again, 10 to 15%, and then you have it for sure. So just having those numbers and trying to explain that and building up trust. I think you need to understand, but I would never recommend waiting. Mm-hmm. And if a patient decides to do that, of course the follow-up would be imaging. But we know the likelihoods of a ventral or lateral leak to close by itself after 4 to 6 weeks is almost nothing. So yep. Of course, you can do follow-up. I will already tell them beforehand what I will tell them the next time and the next time and after that. So I think that's
very clear.
Yeah. So we've a question then from Mark on the chat asking, in a situation where the leak has been sealed, how quickly do you think the CSF that's pooled outside of the dura, how quickly should that resolve and disappear from the image and then have clear images?
Perfect question. I'm waiting for some research to answer that. And probably there will be no clear cut. Mm. In many cases where we know follow-up within a couple of days, we often find early resolution. Mm-hmm. But that doesn't mean it needs to be there. And probably we don't know yet about some slacks are sealed within. So they are less likely to resolve fast. So it's, again, an individual probability, but we want this, like our standard procedure is a follow-up after 3 months. Mm-hmm. And after that, also the everything, the changes in the MRI we always see after surgery. If it's after surgery, of course, in SLAC positive, then we can be sure, okay, now we can reliably interpret the findings, the MRI, and then we want SLAC gone after 3 months, the latest.
Okay, brilliant.
And then going on to the other questions. So a patient has asked if your treatment or aftercare pathway differs in people with dural ectasia, or maybe expand it to sort of connective tissue diseases.
Oh, that's difficult. I might just maybe put the question the other way around. We have of course, it's also part of the disease, and we have very, very few connective tissue disorders with SIH. Usually, I think that's something that's women and difficult to treat. And usually it's rather Marfan that we look into withdrawal ectasia, and there are not that many with actual SIH. So if we talk about SIH, that's our standard aftercare. With everything else, that's more rare than that.
And it's something else. This is probably a
Ritual
different
pathway, and then we follow up. I think that's a very, very important question. I think the MRI follow-ups are very important with them because they can develop superficial desiderosis on their own. But it's also it's based on case report and discussions with centers like Wouter Schiebings and so on. And then we try and figure out the best way for this person.
Brilliant, thanks. So you mentioned venous pressure and CSF pressure. In your opinion, do they correlate, or what's the relationship between them?
Yes, that's one of the things that are proven. Mm-hmm. And I myself did some work on that with MRI studies, and we know this from other studies. That's one of the things. It's what I mentioned it first. Neurologists usually don't know that. Neurosurgeons do.
Yes.
They like the venous pressure is closely linked to CSF pressure. And of course, very elevated systolic pressure pushes up volume that makes headaches as well. But this venous pressure and venous outflow is resistance to CSF outflow, pretty much. If that's high, CSF cannot go out.
Mm-hmm. Mm-hmm. There's a question about pregnancy and giving birth after treatment of a leak. So I'm presuming this is in the scenario where a leak has been identified and has had some definitive treatment, surgery or embolization. Are there any precautions that should be taken or any complications that are known in pregnancy?
No, clearly no. And after surgery or embolization, we have a short period where you need to take care and don't exercise heavily or do not do heavy turning with lifting or so on. But after we have our follow-up, we clear every patient of every precaution. Then the next step is to get back into a healthy shape. And no restrictions on pregnancy or whatsoever. Nothing. And we can even, I can absolutely base this on some data. In IIH, there's now some data coming up. I think most worried that within pregnancy or giving birth in this part, the pressure rises and they might get another leak or something would reopen. By now, there's no such data in SIH, and I would not prevent surgery, do something else, or to go into C-section or something like that. If you want to, do it. If you feel better with that, that's another point. But from a medical point, I do not even recommend this for IIH patients. We have data on that. You can deliver on a natural way, and that's absolutely fine. And the human body, the female body, can cope with so many things like giving birth, which is quite a strange thing. But no, please, after treatment, live your life. At that point, it's so unlikely to have another leak, and just living the fear of another leak puts so much more pressure on the life. Yeah. It's not, absolutely, with all my heart, with everything, no precautions on that.
And there's another question that's very similar, which is someone six months after surgery, is it safe to resume bending, lifting, exercise? And I presume your answer would be the same.
Yeah, and we do have even professional sports going back. We have diving and like airplane rides and so on. People fly in, fly out to get treatment here, so that we can be quite sure it works. And no. Go back to whatever is your heart there.
I would say from a patient perspective, it's very understandable to want to run a mile from another spinal needle after going through the whole thing. So yeah, anyone who's in that position, my heart goes out to you because it's not the easiest decision to be making. So we've talked about the fact that, oftentimes it's more women than men are affected, and they tend to be in their 30s to 40s. And we have a question here about somebody who, is over the age of 70, and they're just wondering, there's not a lot written about older people who have CSF leaks, and maybe it's that we just don't get them coming through as much. Do you have any experience of that cohort?
Our cohort covers patients from 11 to 90 years.
Very good.
And of course, it happens in the elderly. CSF venous fistulas are more common in the elderly.
Mm-hmm.
And we don't do anything different by now. And they're just likely to recover. Sometimes, that's just a gut feeling, and I have no data on this. But I think sometimes they're more diverse. Like picking up on the symptoms is not that particular, but I think actually same rules apply. You need to go back and ask them for the beginning, and they may face the same problems as a 35 female healthy person. You go to a general practitioner and say, I have these headaches and I need to lay down.
Mm-hmm.
Of course, it's migraine, and older patient goes, I have this weird pain in my neck, and then they go to then see an orthopedic or physiotherapist and so on. I think there are so many ways to go wrong that probably we don't see that many. Nevertheless, I think from our cohort, which is quite large, if you look into the Cedars-Sinai cohort, it's the highest numbers are within the reproductive ages, working ages, a little bit more female than men, but so I think that's probably the spectrum. And I'm curious what we see in the next years with the older patients.
Thank you. We're just hunting through now.
So my internet connection is perfect. Looking at the more recent questions, so somebody has asked whether chronic fatigue is something that is seen in patients following a CSF leak.
Yes, of course, and I think there's probably I don't know whether I understand the question. We have this a lot in our patients as one of the symptoms, and it usually depends on how they describe it and perceive them. Like many say, okay, this brain, I'm so tired, I cannot go out. I don't know, my pain is not that bad, or I don't even have pain, but I have this, I'm so heavy. We have this. Also, I would say fatigue is a symptom we see in many, many diseases. So it's, for me, not a major symptom where I would pick up on SIH, but I would always, no matter what the patient comes to my outpatient clinic, no matter what they have, I always ask about the beginning. How did it start? And usually then we can get into some guesswork whether it's SIH. But fatigue is seen in so many diseases. But of course, we have this in SIH as well.
We have a question about superficial siderosis. I'm just asking, is there any way to reduce the risk of superficial siderosis in recurring or treatment-resistant leaks?
Closing the leak.
Yeah.
Yeah. Recurrent. If I hear this question, I'm wondering, like, I think what we need to be aware of, that we see a lot of patients who think they were treated, or they went through hands with not that much experience in dynamic myelogram localizing the leak, and they have been treated maybe for disc herniation or bony spur, and they are told, okay, now you're sealed and you need to cope with that. And so again, the follow-up is very important. And then maybe the team tells them, okay, that's just reoccurrence of the leak, we need to attempt another time. Usually in the retrospective, we see that the leak was never localized,
okay,
and never treated in a right way in those patients. But it happens in our center as well. We do have reoccurrence of leaks because 3% need to have re-surgery, maybe because of the attempt through the door, or the original leak is again open. That's why we always need to follow up, and that happens to everyone. We need to be clear about that. But many of those stories we get with reoccurrence of leaks have not been treated adequately in the first place.
Fair enough. Yeah, and that's something that doesn't doesn't show up for a while, a number of years.
And everybody gets better after treat, like surgery, blood patching, targeted patching. Usually patients improve because it does something to the pressure, but we need to have the resolution and imaging, and only that reduces the risk of superficial siderosis, not whether this leg is less or what the brain of, we know that burn score will improve over time because these, and we don't know why, but
yeah,
that doesn't tell us anything whether the risk of superficial siderosis is less. So closure of the leak.
Thank you.
Yeah, I think we're almost out of time, so I think we'll probably have to draw things to a close very shortly. Are there any last questions that you can see, Claire, that we haven't addressed?
There is a question that comes up from time to time about the relationship between a spinal leak and a cranial leak. So we have a question saying, can a nasal leak happen after a lumbar blood patch? But we do hear this from time to time, that people get clear fluid coming out of their nose while they're undergoing investigation for a spinal CSF leak. And I was just wondering, is that something that you see or people complain about?
Okay, it's a very interesting question. I think it's an area I know some are trying to follow up on. I think it's important to discern nasal leak, actual leak, like where the bone is broken and CSF oozes out, and increased rhinorrhea. And there are different causes why you can have increased rhinorrhea. So we might need to discern that. Nevertheless, we all know this. There's this description in some of patients that they have the feeling of something tripping and oozing and weird taste of things we haven't understood yet. And sometimes get this from other diseases as well. So I have not wrapped my mind around it. To come back to your original answer, we don't have this in examinations during myelogram. Pressure, yes, but not tripping.
Yeah, I think a similar question might have come up before. Sanjay, I don't know if you've frozen on us there.
Yeah, I think.
Sorry, can you hear me?
Oh, it's okay. We were just talking about nasal discharge that can sometimes be mistaken for cranial leaking, and I just was wondering what your approach is.
I presume this is an answer to the question about whether a nasal leak can happen after a lumbar blood patch.
Yeah.
Yeah, I'm not aware of any sort of documented sort of cranial CSF leak happening after a blood patch, but yeah, we have had patients who report rhinorrhea, nasal discharge, after CSF leak procedures or as part of their symptoms of SIH. And yeah, I agree, we don't know why that happens. Patients with severe headache disorders of any kind can get
can get rhinorrhea, I think was the end of the sentence.
So you can get what's called cranial autonomic symptoms, which are sort of a reaction to having pain in the head and face, and it's possible that could be one of the reasons. But yeah, we don't understand this very well.
Yeah, sorry, Sanjay, you just your signal dropped for a moment there, but I think we got the gist of what you were saying. And it's just gone past now, so I'm going to draw this webinar to a close. And I'm going to thank both Dr. Wolf and Dr. Chima. It's been a really good webinar, and thank you for being such a good sport, answering so many of our questions, some of them which went the whole gamut of the whole experience, from pre-treatment, treatment to post-treatment. And it's been really interesting hearing from the Freiburg experience as well. So thank you so much, both of you, for your time. And hopefully you can go and enjoy the rest of the sunny day that's out there. So
thank you. It's been a pleasure. Thank you, both of you.